Hello, everyone. I love this music, but probably we have to cut the music down. Thank you. All right, well, thank you everyone for being here. I'm Fouad Chebib, one of the nephrologists at Mayo Clinic in Jacksonville, Florida. And I was tasked to give you some kind of understanding on how we predict how we forecast what's going to happen to our kidneys as PKD patients. So just kind of as a start, by raise of hand, how many has, if you don't mind sharing, how many has ADPKD? Awesome, all right. And how many are caregivers for ADPKD? Great, thank you for also being here. And how many are professionals helping with ADPKD? Awesome, awesome. Well, so we all come together. Really, we can't do it without you, without understanding the disease. So all this, what's going to be presented is through you, through your participation in clinical trials, in clinical studies, and then the collaboration between academics, so physicians who are in universities and academics, institutions with industry, pharmaceutical companies, and the PKD Foundation, as well as you. So thank you for everything you've done. All right, so I think this is the most important question I feel all our patients need to understand that we have answers for. So sometimes my patients don't know that there's an answer where we can predict what's going to happen for our kidneys. So it's great that you have that education here, and then when you go back to your nephrologist, and if you don't have that information yet, it's good to ask for it. And as a PKD Foundation, we're trying to raise that awareness for all of our nephrologists as well as you. And so you go back home and you ask for your total kidney volume, Mayo imaging classification, when it is predicted for me to have a kidney transplant or need for dialysis. So that's a very important information because you're going to probably adjust your life in a way, probably around that information. Many of you might have a family history of polycystic kidney disease. Does anyone has no family history? No one else in the family has PKD? Okay. So for those who have family history, they have kind of a reference, and most of the times you think that you're going to reach kidney failure around the same time as one of your parent or cousin or uncle or aunt or grandparent. But then the ones without family history, it's a little bit harder to have that reference. And then I'm going to show you that every person has their own journey. Even if your family didn't do well, you might not do the same. So, all right, so we have a lot of slides. I might kind of go through quickly with some of them so we can let some time for questions. So let's get to it. This is something that the foundation would like us to kind of go over that. The whole presentation is through my talk, and they don't have anything to do with the material, so they want to make sure that it's there. And then no conflict of interest in terms of financial conflict of interest. So I would review over the next few minutes kind of the basics of kind of predicting what's going to happen with your own PKD kidneys, discuss total kidney volume, which is hopefully everyone has kind of that ability to get to that. Also kind of how we can use that total kidney volume to predict kidney failure, and then analyze how things are affected by the genetics, and then summarize a little bit how can we do about it. So now that we know the prediction, how can we do a little bit better, and hopefully a lot better. All right, so the first step is to really have an accurate diagnosis. So not all kidney cysts are ADPKD. So most of the times it's going to be ADPKD, but some cases are a little bit more tricky. If it's ADPKD, it's going to be inherited through an autosomal dominant inheritance, which means most of the times there's going to be one parent who has the disease, and then each child would have a 50% chance of having the disease. So it is possible that you have many children with none of them have ADPKD, or you could have some with ADPKD and some without, or all kids with ADPKD. So each child has their own 50% chance. Now, in some situations, as we've seen, there are some patients without family history. So there could be a few scenarios where it could be de novo mutation, and many of you call it I am the mutation, so I'm the first person who has the disease. That means that when you were in the womb of your mother, that's when the mutation or the change in the DNA occurred, and then you develop PKD. It is possible that you could pass it on or not. It depends on where the mutation affected and what level of the development of the embryo happened. But many times it could be that the parent had a mild disease and that was not diagnosed. And many times I've seen actually many patients who've come to me and say, I have no family history, and then a year or two later, they realize that their parent had PKD, but they've never been tested for it. So that's kind of potentially one option. And then it doesn't, if there's no family history, it doesn't mean that your father or your mother is not your biological father or mother. I've seen that a couple of times. And I had to really convince the patient that, no, this happens. You know, don't question that, who is your biological parent. So I like to mention that. So again, I mentioned not everybody with kidney cyst has ADPKD. ADPKD is the most common, but there are many other things that can cause kidney cysts. So make sure that you have the right diagnosis. Those are a few options, a few different entities that in our clinic, they were diagnosed with ADPKD, but when we listened to the patients, we obtained genetic testing, we looked at the kidneys, how they look on CT scans or MRI. They did not have ADPKD, and that's important because that's going to change how we predict things. That's going to change your ability to be on different medications or clinical trials, so it's important to have an accurate diagnosis. I won't bother you with the genetics, but just to let you know that there are many things that can cause kidney cysts, many different genes. So you're very familiar with the PKD1, PKD2 genes. So PKD1 is the most common, most severe. PKD2 is about 15% of ADPKD patients, less common, less severe, about 20 years onset of kidney failure after PKD1 on average. And then there's other things that are now we're discovering they are the third most common PKD genes, like IFT140. There are things that can cause more fibrosis and scarring of the kidney. And there are things that can cause more liver cysts and very few kidney cysts. And in these situations, the kidneys usually don't fail. So again, it's important to have that characterization through genetic testing if there's a question mark about the diagnosis. And then the second point is not everybody with ADPKD is going to have the same outcome or the same prognosis. Some would do very, very well without needing without reaching kidney failure, and some might reach kidney failure a little bit earlier. So here kind of we show in our cohort we had about 1,000 patients who reached kidney failure, and half of them reached kidney failure in their mid-50s and a three-quarter in their early 60s. Here we show the difference between males and females. Usually females have a little bit better prognosis. They do a little bit better. And then here you see kind of patients who are males, they almost all reach kidney failure by age 80, but not everybody reach kidney failure early. So you can have kind of just chronic kidney disease and then reach kidney failure much later in life. And then females only, you can see well from here, 77% reach kidney failure by age 80. So they have a little bit better kidney prognosis, but maybe the liver has a little bit more severe phenotype in females. And your journey might be different than your family member. So here I'm showing that there's really a spectrum of that phenotype. We call it phenotypic variability. So not everybody who has kidney cysts is going to have the same journey in terms of failure or the decline in their kidney function. And even if they inherited the same exact mutation as their family members, so for example, here you see a patient who has PKD1 truncating mutation. That means that the PKD1 gene is kind of the mutation or the change in the code of the DNA led to destruction of the polycystin protein. So the polycystin protein is not functional. And so we expect with these mutations that the disease is going to be a little bit more severe. But here's pleasantly surprising that this patient doesn't have a lot of kidney cysts despite having a severe mutation versus someone who has about the same age. So this is a 36-year-old male who has very big kidneys, a lot of cysts, and they already have decline in their kidney function in their 30s and having that PKD1 truncating mutation. So also be aware that even if you inherited a severe mutation, it doesn't mean that you're going to have a poor outcome. There's a lot of factors that I'm going to mention that kind of are interplay in this. This is showing kind of that interfamiliar variability. So not all of patients within the same family would have the same outcome, meaning here we show someone with PKD1 truncating mutation, and we say, okay, most likely on average you're going to reach kidney failure in maybe in your 50s. But here someone reached kidney failure at 38, and in the same family someone else reached kidney failure at 68. And then here we see different pedigrees and different families. And on average, we saw about 14 years difference between family members, their onset of reaching kidney failure. Same for PKD1 non-truncating and PKD2. We only had one family in this situation. So again, the reference of the family or when other family members reach kidney failure might be right, but you might do a little different. So in general, when someone in the family reaches kidney failure before age 55, we think that you might have PKD1 mutation in the family, and most likely it's the same mutation and the same thing that you inherited in the family. If someone in the family reaches kidney failure after age 70, we think that more likely the family is gonna have PKD2 mutation. All right, so that's something for your reference as kind of prognostication or predictions. So as I mentioned, it's not only about what you inherited as a PKD gene mutation. There's many things that you inherited from the same parent who has PKD or the other parent. Those we call them modifiers. So other things that you've inherited that could make the disease a little bit better or a little bit worse. We still can't pinpoint them exactly, but we're trying to do some research on that. There's also things that are called epigenetic changes. So even a twin brother or sisters could have different severity of their disease, because after we're born and with all the set of the genes and DNA, things change after that in the cells. And then there's a big factor that's environmental factors. So this is kind of how you are motivated to be the healthiest possible you can. In other words, the way how you behave over the years is going to affect how your kidneys are going to do. So many times I hear patients that, okay, I'm doing better because I've been drinking a lot of fluids. I made sure that I lost all my excess weight. I don't gain any more weight. I'm cutting my salt. I'm cutting my calories. So these different things can affect how the kidneys are going to end up behaving. Okay, and all those affect how much of a thirst hormone we have. That's the vasopressin, and affects how much numbers of kidney cysts and how much they're going to grow. Those are all the different pathways or signaling that are abnormal inside the cells due to that low level of functional polycystin protein. But how can we look at all this? What we do is we ask you a lot of clinical questions. We ask you if you've had a bleeding or gross hematuria or bleeding that you were able to see or feel, maybe kind of acute pain that's potentially a cyst rupture. We ask, and if that happened before age 35, that's an indication that potentially you might have a little bit more severe disease. We ask you if you have cyst infection or kidney infection, not just a bladder infection. We look if you had high blood pressure before age 35. All these are factors that kind of, in our mind, we kind of add them up and then might kind of tell us that you might have a little bit more severe disease. The most important thing is to look at how your kidneys are looking. So that's called the total kidney volume. So it makes sense. If you have bigger kidneys at earlier age, let's say I'm 20, 25 with very big kidneys, that's going to be a severe disease versus someone who's 70 years old with few kidney cysts, but the kidneys are not that big. And so total kidney volume is a number that kind of puts a number to that and then lets us kind of do the scaling for it. Now, when we adjust it by age, we get something called Mayo imaging classification, and I'll show you that. There's other things that we're trying to kind of incorporate into practice, like how many kidney cyst number you have, but those they have not reached to everybody's practice yet, because it's a complex way of getting that. Also, what your nephrologist might kind of look at is how fast your kidney function has been declining over the years, and I'll show you a few graphs on what you would expect in your situation. So here I'm showing two cases, two 27-year-old males that have the exact same kidney function. So eGFR is the estimated glomerular filtration rate. That's an estimation on how your kidneys are filtering. That comes typically from a blood test called creatinine. And creatinine comes from typically the muscles. So if you have a little bit less or more muscle weight, muscle mass, that might affect the estimation of the formula. In general, we kind of think that eGFR, or the estimated GFR, kind of estimates close to the true kidney function that you're in. So now 91 is pretty good. That means that the kidney function is normal. We're typically born with 100 to 125 ml per minute. Sometimes we say percentage just to make it simpler. So let's say both of these patients have 91% kidney function. But when we look at their kidney, here MRI or CT scan, we know that this patient is going to has more severe disease than this patient. So this patient both have ADPKD. Patient B has just few kidney cysts. The kidneys are not too big. Here we're kind of taking a cut of the kidney like that. And this one is axial, so we're kind of cutting kind of the images like this. So how can we estimate that? So we have tools to be able to predict that for you in the clinic. So let's go over how we predict this. So for this patient, I would tell them in the clinic, I estimate that you're going to reach kidney failure or need transplant, hopefully preemptive kidney transplantation before you need dialysis. We estimate that in 13 years, you're going to reach that point. And then for this patient, I'm reassuring them, you're going to reach kidney failure maybe in 43 years from now. So for them, they're going to be reassured that it's not imminent, and they're going to have adjustment of their lifestyle in a different way. So maybe I'll skip through that slide given the interest of time, but there's many things that we call biomarkers, and those are trying to predict how severe your disease is. We hope that in the future we're going to have, and then we mentioned the total kidney volume. I'm going to give you more information on the Mayo imaging classification. Here I'm showing something called PRO-PKD score. That's a scoring system that's based on these clinical information I mentioned, so cyst bleeding early on, high blood pressure early on, and then if you have PKD1 versus PKD2 mutation, that helps us predict if you're going to reach kidney failure by age 60 or not. So that's kind of the prediction that it gives us. Other things that we're interested in is things that are called response biomarkers, which means how can I tell in real time if the treatment is working, and how can I tell in real time if you have severe disease or not. These are in clinical trials right now, and hopefully if you're not on tolvaptan already, please consider being in clinical trials, because all this information helps us and helps your family and helps us move the field forward. So again, we talk about renal function, GFR. Typically, patients with ADPKD, they would have normal kidney function for the longest time, kind of their first, second, third decade. You don't expect your creatinine to be abnormal. And sometimes it even doesn't flag on your blood work. But always look at the eGFR, don't just focus on the creatinine number. Because sometimes the creatinine could still be normal, but the GFR is still like 75, 80, or it just tells you above 60. So you have to kind of ask for the exact number for you. So in general, even if the kidneys are so big with a lot of cysts, which is devastating, right, for you to see that. So I'm sorry if I'm showing you pictures that you don't like, but it's good more knowledge is better. So typically, despite having PKD, you might have normal blood work. And then later, you're gonna see that decline in kidney function. So year after year, that creatinine number is gonna bump up, and then that GFR number is gonna slowly go down, okay? And everybody has a little bit different rate of how to kind of slow down. So early on, to be able to know who has severe disease versus mild disease, is we have to look at total kidney volume. And later on, we combine these creatinine numbers, eGFR, plus the total kidney volume. This came to fruition through the effort of CRISP study. So this is a landmark study that was through Mayo Clinic, Emory, Atlanta, Alabama, University of Alabama, and Kansas University. So through the effort of Dr. Grantham and Dr. Torres, Dr. Chapman, hopefully I'm not missing anybody. Who am I missing? And Dr. Mrugh recently. So all these centers have recruited about 200 patients, and they followed them for this study for 3 years. And now we are following these same patients, or a subset of these patients, for 20 years. So now we understand how things work in PKD by following for decades, for 2 decades, these patients. And this kind of showed us that total kidney volume, the higher we have total kidney volume and the faster the kidneys are growing, the faster the kidney function is going to decline. That was very logical, but that was kind of pinpointing. Now it's logical, but back then it was very difficult to kind of have these biomarkers. And then later, at 8 years mark of following these patients, they showed that every increase, every 100 ml, so that's how big the kidneys are, ml per meter, we adjusted for height. Every 100 ml per meter increase, it increases the risk of reaching stage 3 kidney disease by 48%. Which means also another way of looking at it, it depends on how big your kidneys are. We have some predictions of saying, okay, in 8 years, you're going to have CKD or chronic kidney disease stage 3. So those were kind of the initial studies. And now, based on all this, the FDA has approved total kidney volume to be a prognostic biomarker, so to kind of understand how severe your disease is and what to predict in the future. We used to have to go through a very difficult process where an imaging analyst has to go through each of the slices of the images and then trace the kidney and then get the volume. Now we have the use of artificial intelligence and machine learning, and within seconds we can pick up on the kidney and get the volumes. So always ask about your TKV and nag your nephrologist for a TKV, please. All right. Now also we have it at Mayo and hopefully in other centers. We have incorporated this in our practice where whenever we order your MRI or CT scan, we can, the radiologist gets these images right away within seconds and incorporate that in your report. So we're trying to advocate for all the centers and hopefully with the help of the PKD Foundation to have access for all the patients around the United States and hopefully globally to access the ability to get total kidney volume. So we're working on that. Now, why is this important? So I mentioned the Mayo Imaging classification. So with this classification, we say if you are typical or atypical. So 95% of patients with ADPKD, they're going to have typical disease, which means that both kidneys have cysts, and the cysts are almost equally contributing to how big the kidneys are. You can have very mild disease, you can have very severe disease. And so having one image, we can predict how fast your kidneys were growing, and then from that, we can predict how fast your kidney function is going to decline in the future. And we think that Mayo Imaging Class 1C, 1D, 1D are patients who are at risk of progressing a little bit faster, which means when I get your total kidney volume, I adjust it for your height and your age, and I kind of say, okay, you're here. So I'm predicting that, so let's say Mayo Class 1C. And I say I'm predicting that your kidneys were growing more like 3 to 4.5% per year since you were born. And then because of you're here, we're going to predict how your kidneys are going to, the kidney function is going to behave in the future. And I'll show you these graphs in 1 second. But the atypical is about 5% of the patients. So you might have one kidney that's very, very cystic and the other kidney doesn't have much cyst. Or you can have few kidney cysts that are super large. You don't have many other kidney cysts, and those kidneys are contributing to almost half of your total kidney volume. So in these situations, it's very good prognosis. So for these patients, it's a good day for me because I tell them, you're not going to reach kidney failure. Don't worry, you have ADPKD, but you're not going to reach kidney failure. So that's probably 4 to 4% of the cases. And then the way how to think about it, it's probably you have PKD on one side, but the other kidney is completely normal. So, you know, even for you as patients, you probably can see that if you have normal kidney on one side, you're going to do well because it's almost like you donated that kidney out and your kidney here is still functioning and you're still going to do very well. It's as if you are a kidney donor, basically. And even here, so if I look at the images, and I see that there's a lot of preserved kidney tissue, parenchyma, I know that you're going to do a little bit better than expected, okay? So sometimes total kidney volume, we shouldn't take it very blindly. So it's important to kind of take a look at the images and kind of make sense of all the situation. The other, a little bit rarer, but we see it, it's class 2B. So patients might have polycystic kidney disease on both sides, but also the kidneys, as you see here, are shrunken. And most likely these patients are smoking, they have heart disease, vascular disease, they have high hyperlipidemia or high cholesterol, and they didn't do very well. So the kidneys are kind of shrinking and they won't do very well. Most likely they won't benefit from tolvaptan, and the focus would be to keep them as healthy as possible so we can get them to transplant as healthy as possible. So here are the Mayo classifications. So let's say you're Mayo class 1C, 1D, 1E, or 1A. So 1A, you would not reach kidney failure, but you might reach chronic kidney disease later on in life. 1B, you might reach kidney failure, but maybe in your 70s. 1C, maybe in late 50s, 60s. 1D in their 50s, and 1E in their 40s. That's the average. Some do better, some do a little bit worse. And then here we show that when you know your Mayo imaging classification, you're gonna know, per decade how much to expect for your GFR to decline. So if someone has Mayo class 1D and they're, let's say, 35, I kind of predict that they're gonna decline every year by about 3 to 3.5 ml per minute every year. But then when they go a little bit older, they're gonna decline by 4.7 or 5 ml per minute per year. So that helps you kind of know what's the predicted, so you know where you're going, okay? And here we show that patients reach kidney failure in a large spectrum. So some patients didn't reach kidney failure here until their 70s. Here it's a cohort that everybody reached kidney failure. So some of them that did not reach kidney failure are not included here. But we looked at the patients who already reached kidney failure, and you see a spectrum. So some patients in their 30s and some patients in their 70s. The average, as I've been hearing, that kind of your benchmark is 52, 58, 68. So it depends on kind of the numbers that you're hearing, but those are averages. It doesn't mean exactly that you're going to do the same thing. Okay, so this is the average of the whole room, for example, which is going to be true, but some would do better, some would do maybe a little bit less better. All right, so let's say your nephrologist doesn't have a fancy tool to get the artificial intelligence to give you that volume. I would like you to refer your nephrologist to this, what's called Mayo calculator online. They can look at your images, and if they don't have access to your images, each time you do a CT scan or MRI, keep a disk with you and keep it with you. That's going to be very helpful. Once you see a PKD specialist, they can upload it in their system, and they can measure themselves the total kidney volume. So what I would do is, once I upload it in our system, and even if I don't have the AI, I would go and measure how big the kidneys are on each of the levels. So the maximum sagittal level, so it's kind of taking the kidneys this way, then this way, then this way. And then we plug it into an online calculator, and then we get the total kidney volume. So it's not very difficult. You just need to push your nephrologist to do it. And then we adjust by age at time of the image, by height, and then I give you exactly where you are. So this is, for example, a patient who has total kidney volume of 2,000. A normal kidney volume is 150 ml per meter. And then here, it's 1,150 when we adjust it for the height. So the patient is here. So they have a little bit more severe disease. And we also plug in their creatinine number, and then we can predict when they're going to reach kidney function of about 10%. So once you reach about 10%, that's when you're going to need either dialysis or transplant. And since PKD is a predictable disease, you're not going to reach kidney failure tomorrow. It's not going to be acute. You're not going to wake up with kidney failure. You're going to be living a normal life. You're going to feel fine. And then your blood work is going to show some progress every year. Okay? So we have a way to say, okay, now you reach kidney function of 25. Okay, maybe in next year you need to be on the kidney transplant list, right? So anytime you reach close to 20 ml per minute, you need to be on the transplant list. Don't let your nephrologist not do that. Make sure you go there. And once you're on the transplant list, you're building up the time, and then you're trying to kind of prepare for the next step. The best next step is to have a living donor. So I know there's caregivers here. Most of the times it's a partner or your child or your sibling or a friend. So don't feel afraid to take a kidney. It's the biggest gift, but allow yourself to take that gift, okay? Because it's gonna affect your family. It's a two-way street. So even if a partner give a kidney, they're gaining out of that because they have you as a loved one still with you, having good quality of life. All right, so here we predicted for this patient, they're going to reach kidney failure in 14 years. So now what can we do about it? Hopefully, I have 10 more minutes.
Yes, I was just going to remind you.
Okay, maybe I'll go to what can we do about it a little bit so you can have an idea what to advocate for yourself when you go back. All right, so we mentioned that pro-PKD score. So again, it's kind of a group prediction that if you have a score of 7, 8, or 9, you're very likely you're going to reach kidney failure before age 60. Also, it predicts if you're going to respond to tolvaptan or not. So patients with score of 4 till 9, so intermediate risk and high risk, they would benefit from tolvaptan treatment or GnRQ. I'm a pro-advocate for getting genetic testing, although this is controversial. Yesterday, our PKD clinic directors didn't agree all that it needs to be done. I agree that we need to get, I propose that we should get genetic testing for everybody. The more information, the better, the more characterization is better. And now it's quite affordable, so it's not, it's quite affordable and it gives us a lot of information. Let me skip through that. It's just maybe one take-home message is that when a patient with PKD is getting a little bit older, there's other things that are affecting the kidney, not only the cysts, but rather aging of the kidney, scarring of the kidney, maybe some vascular disease. So this is another reason why we need to stay very healthy. If someone is still smoking, I'm not going to ask for a raise of hand because I might get angry. So whoever is still smoking, please stop smoking today because it's very bad, right? So it's very bad on the kidneys. It's almost as you have diabetes on the kidneys if you smoke. And then so give yourself a chance to kind of, not reach kidney failure. So cardiovascular disease can affect, so scarring of the kidney from that can affect reaching kidney failure a little bit earlier. And then also I'll skip through that for the sake of time. This is an important thing. You're all interested about PKD diet, I'm sure, and there's going to be sessions about that. We're putting out a lot of educational material, things that we publish that are easy for you to read. The take-home message is you need to try as much as possible. It's very difficult. I know personally that it's very difficult to lose weight. But the more you try, the better, right? So it does pay off to be healthy with PKD. This is showing that if someone with PKD has overweight or has a little bit more excess weight, they're gonna have their kidneys grow faster as compared to someone with ideal body weight, okay? And again, I'm not saying it's easy. I'm saying it's very difficult, but you have to try because that's something you have control over, and it's gonna be very impactful on your disease. And it's going to be very impactful when you try to cross that bridge to transplant. So if you have high body mass index, your recovery from transplant is going to be difficult, and some centers have cutoffs. If you have really very high body mass index, you might not be eligible to be on the transplant list. So try to be as proactive from day one from the diagnosis. And also, your patient, your children, if you have children, are at risk of PKD, whether they're diagnosed or not. So try to establish a healthy lifestyle in your house. So a lot of good drinking of fluids, and then as much as possible, have the grocery at the perimeter of the grocery shop and not inside. So no processed food, nothing from the fridge or the freezer. All as much fresh as possible, although it's more expensive and it's more difficult, but it pays off. It's gonna pay off. You're gonna still have your job when you're 50, 60. You're gonna still see your grandkids, so it pays off. It's a lot of work, but it pays off. All right, let me skip through that. We talked about this, so there's a distinction between having a risk of progression versus evidence of progression. And that means that right now you have normal kidney function, but you're at risk of losing that in the future. That means you have risk of progression. Versus right now you have chronic kidney disease, and we've seen all the kidney function declining year after year. We have proof of that. So this is just this medical distinction, but I'll skip through that. All right, let me go to this slide, and then we still have 5 more minutes. So I'll go through things that you should be aware of, and then we'll talk about GNRQ also, which is important. So we talked about, again, prognostication. Now it's time to slow it down. So anyone who is at risk of rapid progression, meaning big kidneys, so Mayo imaging class 1C, 1D, 1E, we'd like to reach a blood pressure of 110/75. That's an average, so you're going to have a little bit of fluctuation of your blood pressure during the day when you're upset from your kid not doing well, like me yesterday. Your blood pressure is going to go high, but on average, it needs to be kind of 110/75 if you tolerate that. We don't want you to be dizzy and fall. So if you can tolerate that, we'd like that average. So that means that you need to be proactive. Even if I prescribe the best medications and you're not checking your blood pressure at home, or you're not taking your blood pressure at home, you're responsible for that. So you need to take responsibility for this. Restrict your sodium moderately, because that's important to suppress that thirst hormone and control your blood pressure. Drink fluids, not just fluids, water, fluids. We'd like to suppress that thirst hormone as much as possible. So drink fluids throughout the day, and even at night when you go to sleep, have 1 or 2 glasses. If you wake up at night, also drink fluids. So water is going to be your friend, unless your nephrologist is saying otherwise, depending on your kidney function, your serum sodium level, and so forth. So they might adjust that, but be aware that you need to hydrate. So typically we say 3 to 4 liters, but it might be a little bit different for you, okay? Maintain a normal body mass index, so normal body weight. If you restrict your calories by a few percentage, even just 10, 15, 20%, so just portion control, you're gonna gain a lot on that, because you're gonna slow your disease progression. If you have high cholesterol, we have low threshold to start a medication for that, statins. And then the other things are kind of what your nephrologist is gonna look at in your blood work and recommend anyway, depending on your kidney function. We talked about the blood pressure, so I'll skip through those. Just for your awareness, we like to if you can tolerate that, ACE inhibitor or ARB, those are medication, blood pressure medication classes. Then, in terms of the efficacy of being on a lot of water, there's been a study in Australia, and it was called negative. The reason is mostly so there was no effect between being on a lot of fluids versus no fluids or normal fluids. The devil is in the details. So my take-home message from this is that only half of the patients were able to be so regimented and dedicated to drink that much fluids to be able to suppress that thirst hormone. That's why it was negative, in my opinion. So I still recommend patients to drink fluids. It might not be the only solution, but it does help. So you want to kind of gather all these helpful things, your normal body weight, calories, drinking fluids, restricting salt, keeping your blood pressure well controlled, so you can get at least some benefit from each, and then that would help you slow your disease progression. And then diet. So we talked about caloric restriction. So here's the data. Those are animal kidneys. If we let them eat normal, they're going to have kidney cysts. If we restrict their food by 10, 20%, we don't have to do 40%, even just 20%, 15, 20%, they're going to have much smaller kidneys and better kidney disease, or slower kidney cystic disease. Now, this is in animals, and I always say those are very, very interesting studies, but I treat humans with ADPKD. So it's very important to wait for the right clinical data, so please try to be involved in clinical trials. So there's a lot of things going on at University of Colorado here in Denver. They're doing an excellent job and looking at the efficacy of these interventions, dietary interventions, to see if they slow the disease progression, and also to make sure that they are safe, okay? So whatever works on animals might work, and hopefully it will work, but it might not work on humans, and it might not be great for all humans with ADPKD. So that's the message that we try to get across all the time. There are other things that you might be doing already, like ketogenic diet, intermittent fasting. The data for human ADPKD is still missing. There's a lot of ways. There's a lot of trials that are trying to answer these questions, but the data is not out there yet. So there's many benefits, right? Because we reduce the weight, we change kind of how the kidney is working inside the cells. But there's also some side effects like bone growth, fatigue, irritability, things like higher cholesterol, higher risk of stones. So we don't know the long-term effect for these PKD dietary interventions. And for that reason, we don't prescribe them yet. So be careful when you do them because we don't know the long-term effect. And they might have bad side effects. So what we recommend is you want to achieve a normal body mass index and normal weight. That's kind of, I think, if you go home and have that take-home message is, I want to be so proactive, I want to try as much as possible, change my lifestyle to kind of drink more fluids and then cut down on my portion. I think you're going to do very well with that. You might be on ketosidra. That's a beta-hydroxybutyrate. That's something that will kind of reach a ketogenic state in your body. There's been data, in mice, very interesting data, very promising, but we don't have the short-term or long-term effect of these interventions. Those are supplements, so you can buy them online, but we don't recommend them as PKD experts yet. All right, so we talked about this. Maybe I'll do this slide and then we'll take questions. Okay. This is just to give you a lot of hope. There's a lot of hope out there. We have one approved treatment called tolvaptan. It blocks the thirst receptor. So AVP is vasopressin, or the thirst hormone. In normal ADPKD, this gets stimulated and there's more cyclic AMP and more downstream effects, which makes the cells of the kidney grow and then form and have that cyst fluid secretion. So it kind of forms these cysts and there's secretion of these fluids. So cyclic AMP is very bad in PKD. If we have ways to reduce that cyclic AMP, we can reduce how fast the disease is progressing. And that's one way of doing that is to block that thirst hormone here, the effect of the thirst hormone on the V2 receptor. So tolvaptan or GnRQ is the first FDA-approved and only FDA-approved drug for now. And it does reduce that cyclic AMP and reduces all these bad things that happen afterwards, okay? But the hope here is that there's potentially other treatments. There are things that are in phase 1 trials, so those are early clinical trials, and we need you to be in these trials. We need you to have faith in us, in the medical community and scientific community, so we can really push that forward. Because if we go back, I think, let's see, 15 years maybe, without your faith in the clinical trials and without kind of that advocacy and pushing and going through these trials, we wouldn't have an FDA-approved treatment. We wouldn't have any of these now that are in the pipeline to potentially be a treatment to slow your disease progress. So it's kind of, it's collaboration. We have to both kind of work together. All right, so I'll stop here and I'll take your questions.
Do you want to do in person first, or do you want to?
Sure.
Up to you. Do you want to do?
Yeah. Is there a lot online?
So there should be a barcode on one
Okay.
of your
Do you want me to
slides.
get out of here?
Yeah. If you go to the first slide, I think they said they put a barcode.
Oh.
Or maybe the last one. I don't know how they set it up.
Okay, let me go to this.
There
Okay.
we go. Okay.
My apologies for that. So, yeah, let's start with in person and then
Yeah. And let me just
we'll
take
take it
a
from
picture
there.
of it, and then I can see.
Okay.
Okay. We had a hands up here.
I have a comment and a question.
Yes.
Firstly, on the comment, Ketocitra is not a supplement, it's a medical food and can only be taken under the supervision of a doctor. So in that context, some of the risks you mentioned would be addressed in that setting.
Okay.
The question is, the last MRI I had on my kidneys, the radiologist made a distinction between the cysts that were visible on the exterior of the kidney versus what was perceived to be the total cystic volume. And I was wondering if you can explain what the difference is to the patient.
Sure. Let me start with the last question, and I'll go back to the comment. So you're referencing something called exophytic cysts. So the kidney is kind of a bean. Most of the cysts are kind of inside many smaller or medium-sized cysts, and some can be just kind of very, very big cysts or medium-sized, but they're mostly outside of the kidney. Now, the Mayo imaging classification doesn't account for that, but there's now a newer classification that they removed portion of that cyst that's outside of that kidney, exophytic cyst, and that kind of helps predicting a little bit better the prognosis. So it depends on your situation. So if there's only few very large exophytic cysts outside of the kidney, then your prognosis is better. It doesn't make any difference in terms of what you're gonna feel in terms of pain or if you get cyst bleeding. So it doesn't increase its risk of cyst bleeding. It's just kind of probably there's less cysts around it. That's why it was able to kind of grow and go up. That's my personal impression. In terms of the Ketocitra, yes, it's a medical supplement under the or medical nutritional, and doesn't need FDA approval, but it has to be under a dietitian or a doctor. But that doesn't answer the question about long-term effect in patients. So there's no clinical study looking at Ketocitra effect on PKD. It's all animal studies. So you're taking a big leap of faith to do that, which I understand, and I hear you, and I hear patients who are, I have patients who are on it, and I could not convince them to stop it. So you want to do what you feel like it's right for you, but right now we have to be scientific, and we need to have the proof, the evidence. Even if the FDA doesn't require that, we need to be careful because we are actually advocating for you and for your health, so no one kind of just goes out there and then just sells you stuff. That's our kind of maybe idealistic approach of things. Sometimes life is not ideal, and we understand that. I hope I answered the question. All right, we have a few more questions here.
I am wondering about tolvaptan for 18-year-olds or young people.
Yes.
If a nephrologist has said that your child would qualify at that point, my husband is on it. Her nephrologist is saying she would qualify. He does not feel like it's a promising medication. I am totally confused. So I'm just wondering your thoughts about young people taking it who do qualify.
Sure. Who's not convinced? Sorry, I missed. Is it your husband that's not convinced or the nephrologist? Okay. The pediatric. Yes, so that question comes up. So there's several things that are into play when someone is a teenager. So they're probably going through college. They're going to have all different pizzas and things. So they're going to have high salt intake. So probably the tolerability of tolvaptan might be a little bit different. And it depends on their level of kind of accepting to be on a twice-a-day medication and be compliant. So those are discussed kind of in our clinic. In terms of efficacy and kind of being convinced that if it works or not, it's a great question because we have a poster out there that looked at patients who've been on tolvaptan between age 18 to 35, and we've seen that there's a good benefit from that, about 1.7% per year. So we didn't get to these slides, but each year you're on tolvaptan, you're kind of gaining this extra 1.3, 1.5, 1.7%, and it adds up. So if someone has been on tolvaptan for 5 years, or let's say 10 years to make the math simple, you're gaining an extra 13%. And those of you who have seen dialysis or transplant or are in advanced CKD, these 10% are very precious at the end. But it's a lot of work. It's a lot of work for an 18-year-old. It's a lot of work for even 4 years old to be on tolvaptan. So we understand that there's ways to mitigate these, kind of going to the bathroom and kind of work maybe on the dose, but there's benefit. And we know that the earlier we start, the more we're gonna gain on that. But again, we understand that, you know, the start date is not the same for every patient. So someone who's 18 might be, you know, we have, I think, Jeff, who's like the patient advocate that we just listened to. So someone with that maturity, probably he would tolerate it great. Someone who's still kind of going through life things, maybe you want to wait a little bit until they kind of get through college. So it's a shared decision and personalized approach. But it does work if you're able to tolerate it. Yes. Yes.
Okay, this is a follow-on on tolvaptan based upon one of your slides, which I've not taken. If I understood you correctly, the goal of tolvaptan is to suppress the thirst, yet you need to drink a lot of fluids and go to the bathroom. So I was trying to balance the science of that in my mind.
Excellent question, yes. So it blocks the effect of the thirst hormone on the kidney. So that vasopressin or the thirst hormone is not kind of doing the bad thing on the kidney cell, but also it's going to increase the osmolality or the concentration a little bit of the blood, and that's going to be sensed in the brain of that thirst, and then it's going to trigger you to drink all these fluids. So most patients would be drinking 100, 150 ounces a day type of thing. So 4 to 5, 6 liters of fluids throughout the day, 24 hours. So that's a lot of fluids. So that's kind of the main effect or side effect of this medication. But the effect of the thirst is blocked, so that there's less cyclic AMP production inside the cell. Yes, please.
So in terms of progression of PKD, if someone's diagnosed later, like in life, like in their early 40s or something, would that like influence the progression maybe to be faster, or does it vary on each individual case? Because like when I was diagnosed, I was in my early 40s, so just a few years ago. So
Yeah. So not everybody gets diagnosed early. It depends on the situation. It doesn't change your prognosis unless your lifestyle habits were a little bit different. So the good thing, if you're able to diagnose earlier, now that we have a treatment for 18 years and older, the good thing is you're gonna change your lifestyle. As we mentioned, you're gonna drink more fluids, you're gonna make sure you don't gain the weight, you stop smoking if you've been, or don't pick up smoking. So all those are the small things that might affect your progression, but overall, in the big picture, if you've been healthy, it's probably not gonna make a big difference. Yes, please.
We have time, one more question.
And I'll be here, so I'll take all your questions after the session.
I'd just like for you to, the way I think I understood you is you said that if you had cysts on your liver, that you would most likely not have end-stage kidney disease, or it would not go to that point. I do have a lot of cysts in my kidneys. I also have cysts on my liver, and I'm almost 70, and I'm just on very low blood pressure medicine.
Yeah. Let me verify. That's a great question. We didn't have time to dwell mostly into that. So with ADPKD, almost all the patients would have some liver cysts, maybe a few liver cysts. And almost maybe 80%, it would be very mild. It's not going to cause symptoms. And then even if you have severe polycystic liver disease, the liver never fails as a liver. It's fantastic. Even having a huge liver, which pain in the neck, it's very bad to have severe liver disease. It's just the symptoms, okay? So that's one point. Now, in terms of differentiating between autosomal dominant polycystic liver disease versus autosomal dominant polycystic kidney disease, both of them have liver cysts and both of them have kidney cysts. And the ADPKD, the main phenotype is going to be where your kidneys have a lot of kidney cysts, and most likely, you're going to reach some sort of chronic kidney disease at some point in your life, right? You might have mild, moderate, or severe polycystic liver disease with ADPKD. Now, there's a different entity called ADPLD, so autosomal dominant polycystic liver disease. Those are different set of genes and different mutations. The phenotype is mostly the liver is very big, the kidneys have just very few kidney cysts. The main way we distinguish is through genetic testing. or when we look at all the families and we kind of figure out that through the family, the phenotype. Now, these patients with ADPLD, if they have just few kidney cysts, they would not have a bad outcome on the kidney. So it's kind of common sense. So even if we don't have this genetic testing and if we labeled it wrong, if we looked at your kidneys and looked how big your kidneys are and how many cysts, we can predict if your kidney function is going to be good as you're doing now, right? So you're in your 7th decade and you're still doing very well. So that means that your cystic burden is low and most likely you're Mayo Class 1A, just to predict, right? So based on kind of the story, I have to see the images and stuff. And this is kind of give you kind of a feel of what you should have a discussion with your nephrologist. One time after the other. It might not be happening in one encounter with them. It depends if it's a private practitioner, you have to understand also they're under pressure. They have to move every 15 minutes. That's why we're trying to create the PKD Centers of Excellence where there's more time to talk with you and have patient navigators, educators that can also talk to you and kind of get your questions and so forth.
Okay,
All
so,
right.
yeah, thank you everyone for your questions. Thank you for being here. I know it's been, because we've been living in a Zoom world for a while, so it's good to see everyone in person. But yeah, if you guys have any questions, feel free to.
Yeah, I'll stay here. I'll take all your questions. I'm sorry I went a little bit late on the presentation, but.